Hi, my name is Lucy Unger. I'm one of the Global Health Fellows at the University of Utah, working in the Emergency Department. And I'm working with Dr. Mike Morgan. I'm honored today to be talking to you guys about traumatic brain injury in the Emergency Department. So, objectives for today. First, I'd like to define mild, moderate, and severe traumatic brain injury, or TBI. Next, I'd like for you to understand TBI pathophysiology. We'll acquire tools for rapid recognition of the head injured patient in the ED. And then I want you to recall critical actions in the ED management of TBI. Specifically, we'll talk about the management of brain herniation. So TBI is defined as brain function impairment from external force. Now, this definition is incredibly broad, and it ranges from brief confusion related to a bump in the head all the way to coma, severe disability, and death. Talking about TBI epidemiology. So TBI is the #1 cause of death and disability in trauma worldwide. Globally, it's estimated that there are 5.48 million people who suffer severe TBI annually. And men are 2 times more likely than women to suffer TBI. Finally, we see a trimodal age distribution with TBI. So the young adults, and the very old. So between 0 and 4 years old, we have a spike in TBI prevalence. Then between 17 and 24, and then again in patients greater than 75. MVC, or motor vehicle collisions, are the #1 cause of TBI in kids and young adults, with falls being the #1 cause in the elderly. So TBI can be classified as mild, moderate, or severe. Now this is classified based on the patient's presenting Glasgow Coma Scale, or GCS. We'll talk a little bit more about how to calculate that later on in this lecture. Now, mild TBI is what we call a, quote, concussion in the emergency department, and this makes up about 80% of the patients that we see. The vast majority of patients with mild TBI who present with a GCS of 14 to 15 will have nothing clinically significant on their head CT. And mild is actually a misnomer. Many patients with mild TBI can experience severe short-term and long-term impairment. Next, we have moderate TBI. So moderate TBI is defined as a Glasgow Coma Scale of 9 to 14 on presentation. 10% of patients with TBI have a moderate TBI. The mortality is still high, it's 20%, with 40% of patients having something abnormal in a head CT, and 8% of these patients needing neurosurgery. Severe TBI is diagnosed based on a Glasgow Coma Scale less than 9. Severe TBI has nearly a 50% mortality, and most patients die within the first 48 hours. Unfortunately, less than 1 out of 10 patients with a severe TBI will have a good recovery in the long term. So now let's talk about the pathophysiology of TBI. So TBI begins with what we call the primary injury. We have an external force applied to the skull, which leads to shearing of the neurons. And this is the primary injury leading to neuronal death. Next, we have secondary injury. So secondary injury is caused by an inflammatory cascade that brings in swelling into the brain and additional neurotoxic substances that cause more cell death and more neuronal loss. Now, don't confuse secondary injury with what we call secondary insult. Secondary insult is something that we can often prevent by managing patients appropriately in the emergency department. Now, this is defined as hypotension, hypoxemia, hyperthermia, hypo or hyperglycemia, or seizures. So these secondary insults can have devastating consequences on neurons that may have otherwise survived. So when you think about TBI as an injury is different than many other types of traumatic injuries because we're talking about injury to an organ that lives inside of a closed box. So this is a healthy, normal brain, here pictured on the left side of the screen. And this healthy, normal brain has a balance of parenchyma, blood, and CSF with a normal intracranial pressure of less than 10 to 15 millimeters of mercury. Now, unfortunately, the brain here pictured on the CT on the right-hand side of the screen has suffered a traumatic brain injury. And I'll let you take a look at this and find the subdural, epidural, and interparenchymal hemorrhages there. Now, based on this idea that the brain lives inside a closed box, when you have expansion of one of the substances within that box, you get an elevation in ICP. Now, I want you to remember that cerebral perfusion pressure, or CPP, equals the mean arterial pressure, the MAP, minus the intracranial pressure, the ICP. So when we have expansion of blood or edema, as we see in the setting of a severe TBI, we get elevation in our ICP. And when we have elevation in our ICP, it follows that we get a decrease in our cerebral perfusion pressure, obviously if MAP remains constant. So I want you to recall the autoregulation of cerebral blood flow. So this diagram demonstrates the relationship between cerebral blood flow and the mean arterial pressure. And in a healthy, normal brain, we have an exquisite mechanism for maintaining constant cerebral blood flow across a wide range of blood pressures. So when we have a low blood pressure, as we see at a MAP of 50, we get vasodilation within the cerebral vessels. When we have elevation in our blood pressure, as we see at a MAP of 150, we get vasoconstriction. And because of that process of vasodilation and vasoconstriction that we see in a healthy brain, we can maintain constant cerebral blood flow. Now, recall that when we have elevation in our ICP, we ultimately get a drop in our cerebral perfusion pressure. And when our cerebral perfusion pressure drops below 60 millimeters of mercury, unfortunately, we lose this ability to autoregulate. And we end up with a cerebral blood flow blood pressure curve that looks more like this. So we no longer can vasodilate and vasoconstrict in order to regulate our blood flow. So we end up with more of a linear correlation between blood flow and MAP. Now you'll see if we drop to a MAP of 50, we are going to drop our cerebral blood flow potentially dramatically. And as we climb in our mean arterial pressure, we hit a point where that increased blood flow to the brain increases our ICP, which can lead to a complete collapse of the system. So in severe TBI with elevated ICP, it's very important to monitor the blood pressure closely and try to optimize blood flow as best we can. Now, the most feared consequence of a severe traumatic brain injury is brain herniation. And as we have expansion of hematoma and edema, eventually the substances inside that closed box need somewhere to go. And unfortunately, what happens is they end up herniating. Now, how do you watch for herniation in a patient? And how does this manifest clinically? So I'm going to present 3 things that I want you to watch. So the first is the pupil exam. So in patients who are herniating, you will often see changes in pupils. And the most common is a cranial nerve 3 palsy seen in what we call uncal herniation. You may also see bilateral pupillary constriction in response to herniation. Next, you will often see changes in the neurologic exam. Now, most commonly, this presents as declining mental status. And I'd say it is extremely rare to have herniation without a decline in mental status. So that's the first and foremost thing to watch for. But other things to look for would be new neurologic symptoms, as many of the herniation symptoms result in either ipsilateral or contralateral weakness or spasticity. And then finally, it's important to watch the vital signs. In herniation, especially as we see worsening brainstem malfunction, we develop something called Cushing's triad. And this is a process of hypertension, bradycardia, and irregular respirations. So keeping patients with TBI on a continuous vital monitor And watching these parameters closely may show us if a patient is trending towards herniation. So bottom line, in any patient with a serious TBI, you need to closely watch their level of consciousness, their neurologic exam, including their pupils, and their vitals to monitor for signs of herniation. Next, I just want to talk briefly about the Glasgow Coma Scale, or GCS. So the GCS is a useful tool for the rapid assessment of mental status, as well as a useful, objective, and reliable measure to monitor patients for signs of clinical deterioration. And in the setting of TBI, it's very useful for the initial assessment, initial assessment of severity of brain dysfunction and potentially the need for intubation. And then it is extremely important in monitoring patients for signs of possibly expansion or worsening of their bleed or potentially even herniation. So I'll just give you a quick mnemonic that I use to remember the GCS. So we look at the eye response, the verbal response, and the motor response in every patient, and we basically give them a score for each. So how I remember this is eyes, voice, motor. I remember extra value meal costs $4.56. So hopefully that'll be helpful for you. Now let's talk about how we approach patients in the emergency department who present with closed head injury or a traumatic brain injury. So first, I want to talk about just some tools to rapidly identify patients at risk for TBI. Then we'll talk about how do we approach these patients with regards to their airway, breathing, and circulation. And then finally, I want to talk to you about how to manage elevated ICP and herniation. So, how do we identify a patient who is high risk for head injury? So first and foremost, we need to think about the patient mechanism. So if we are fortunate to have a history for the patient who we're seeing, a high-risk mechanism is defined as a pedestrian hit by an automobile, an MVC with ejection, so they flew off their motorcycle or out of the car, fall from greater than 3 feet, or a fall from greater than 5 stairs. Other high-risk features would be a patient presenting with a closed head injury who is on blood thinners, a patient with a GCS less than 15 2 hours after their injury, or obviously any decrease in GCS on presentation, particularly less than 13, suspected open or depressed skull fracture on exam, any sign of basilar skull fracture, so I included some pictures here. A being hematympanum, B is the battle sign, the bruising behind the ear, and C shows the raccoon eye, and these are signs of a basilar skull fracture. Any patient with a mechanism for closed head injury who has vomited greater than 2 times is at high risk, or patients greater than 65. So in these patients who are high risk for head injury, you should be considering neuroimaging like a CT scan. And also in these patients, based on history, if they are deteriorating, you may assume a significant traumatic brain injury until proven otherwise. Now, I'm just briefly going to discuss in patients who are moderate risk, so they're the walking well who come in who've had some impact to the head. You can use clinical decision tools to try to decide who needs brain imaging. And one tool that I use is the Canadian head CT rule. This rule is 99% sensitive for clinically significant traumatic brain injury, and it can be useful to decide. It can be a useful tool to decide who does and does not need a CT scan. And I'll let you look at that. You can review this on your own or find it on MD Calc. So now, in talking about, we've identified the patient. They come in the door. They're high risk for TBI. I want to talk to you about managing their ABCs. One thing that I want to stress is that a single episode of hypoxia or hypotension in a patient with a severe TBI increases mortality by 150%. And so that is why in these patients, our approach to the ABCs needs to be very aggressive. So let's talk about airway and breathing. So we talked about the GCS, the Glasgow Coma Scale, In patients who have a GCS less than 8, the rule is you intubate. So this is because patients with GCS less than 8 likely cannot protect their airways. And if they can't protect their airway and they aspirate, and they have a single episode of hypoxia, we're increasing their mortality dramatically. So remember to be aggressive in airway protection measures for these patients. Now, when you intubate a patient with a traumatic brain injury, I want you to think neuroprotective intubation. So there are some unique considerations in this population. So on the right-hand side of the screen, I have a picture of some vocal cords. And I want you to remember that if you touch someone's vocal cords, that is incredibly irritating. And when you irritate your patient, you elevate their intracranial pressure. We do not want to elevate intracranial pressure in patients with severe TBI because we do not want to cause herniation. So in these patients, we need to do a couple of things. Number one, these are patients that you should intubate with their head of bed elevated 30 degrees. Next, something to consider in the stable patient with the elevated ICP is pretreatment with fentanyl. In some studies, this has been shown to decrease the glottic stimulation from intubation, which may decrease the ICP effect of intubation. Next, and I think even more important, is this is a patient that you really want to use good induction and paralytic agents. So induction, you may choose to use etomidate or ketamine. Both have been shown to be appropriate induction agents. Ketamine may be especially appropriate in a patient who is hypotensive with head injury. And then paralytic agents. This is a patient you may want to use succinylcholine. And the reason why is we talked about how important that neurologic exam is. And so using the shorter acting agents such as succinylcholine may allow for a more rapid neurologic assessment after intubation. Next, this is a patient we want to minimize laryngeal manipulation. So again, this is very irritating. It can elevate ICP. So these patients, I want you to pick your intubation or method of laryngoscopy that you believe is the least irritating to the patient. And many patients, this is video laryngoscopy because you don't have to manipulate the tissue as much. I think this fourth point is the most important, or fifth point, excuse me. I don't want you to forget post-intubation sedation and analgesia. After you intubate this person, they need to be placed on propofol and fentanyl because after 20 minutes, you may start to see a sudden spike in blood pressure. They're irritated. You're going to drive up the ICP, and you're going to increase your risk for herniation if you do not. Finally, neuroprotective ventilation. So this is a patient we want to aim for a PaCO2 of 35 to 40 millimeters of mercury. And the caveat is, if they're acutely herniating, you may aim for a PaCO2 of 30. Now let's talk about circulation. So in severe traumatic brain injury, we have different goals when it comes to circulation. So many of you are probably used to seeing a goal map of 65 in patients with sepsis, for example. In TBI, a map of 65 may not be sufficient to provide adequate cerebral blood flow. Recall the cerebral blood flow curve that we looked at earlier. So in these patients, we aim for a map of 80. Now, in patients who are hypotensive, I want you to think about giving them blood and volume first in most cases, followed by pressors. And that's because isolated head trauma is very uncommon. So when patients have hypotension in the setting of TBI, it's generally because of injury elsewhere in the body leading to hemorrhagic shock. Now, I will say there are cases where you have a high cervical spine injury and may have neurogenic shock. And if that's the case, and if that's your clinical suspicion, it may be appropriate to start patients on pressors earlier. Now, obviously, we use a transfusion goal of less than 7 in patients with TBI, Or we can certainly transfuse earlier if we're concerned for hemorrhagic shock with bleeding. Now, in these patients, it's important to reverse their coagulopathy. This may be coagulopathy from Coumadin or other blood thinner or antiplatelet use, or it may be coagulopathy from DIC. This should be something we think about in our initial assessment and consider early coagulopathy reversal. Next, let's talk about how we prevent other secondary injury. So some things to consider in these patients is placing them on prophylactic anticonvulsants for seizures. So we use Keppra 1 gram BID often, and in some cases you can use fosphenytoin 20 mg per kg up front with 100 TID thereafter. Next, get a temperature in these patients, and if these patients are hyperthermic, you need to start cooling measures. So you can use both Tylenol and other external cooling devices. I just want to point out that there is no evidence for therapeutic hypothermia in TBI, so the goal is just normothermia in these patients. Finally, you may consider putting patients on an insulin drip to maintain their blood glucose between 100 and 180, as both hyper and hypoglycemia have been shown to worsen outcomes in TBI. Next, let's talk about how we manage the most feared complication of traumatic brain injury in the emergency department, herniation. So we did discuss how you identify patients who may be herniating. And recall that clinically, we can identify these patients based on changing in their level of consciousness, perhaps demonstrated by a declining GCS, changes in the pupillary exam, or changes in vital signs, with a trend towards Cushing's triad being a particularly ominous sign. So if you see hypertension, bradycardia, and irregular respirations, particularly in the setting of a declining GCS, we need to be thinking about managing herniation empirically. So first step is, obviously, let's return to the ABCs and make sure that those are optimized. Elevate the patient's head of bed to 30 degrees to decrease ICP, and take a look at the patient's cervical collar. And if the cervical collar might be compressing some of the venous structures of the neck, we need to readjust it. Next, we can hyperventilate patients emergently to a PaCO2 of 30 millimeters of mercury. Now, I want to stress that this is only something to be done in the acute setting, and that is because hyperventilation leads to cerebral vasoconstriction, and if this is done over a period of time, this will lead to worsening cerebral ischemia. So this is only something to do as a temporizing measure. Next, we'll discuss osmolar therapy, and I'm going to discuss this in more detail on the next slide. And finally, we need to arrange for immediate neurosurgery for a patient who we believe is herniating in the emergency department. So while we are doing all of these steps, we are calling our closest neurosurgeon or surgical colleague for intervention. And this may involve a ventricular drain, blood evacuation, or a craniotomy to relieve the pressure. So osmolar therapy. We have two agents we commonly use in the ED for osmolar therapy. The first is hypertonic saline, and this is commonly given as a 500 ml bolus of 3% saline or a 30 to 60 ml bolus of 23.4% saline. Next agent is mannitol. Mannitol we give in a 1 gram per kilogram bolus, but the important thing to remember with mannitol is that mannitol is an osmotic diuretic, and it will cause hypotension. So in a patient who is hypotensive, mannitol is not a great first choice. Next to remember is that mannitol is contraindicated in patients with end-stage renal disease. When you are giving osmolar therapy in the emergency department for herniation, it's important to insert a Foley catheter and closely monitor urine output. And urine output should be replaced with normal saline to avoid hypotension. So we've talked about a lot of stuff today, And I just want to do a quick summary of some of the important points. So I want you to recall that TBI is the #1 cause of death and disability in trauma worldwide. Brain injury can lead to a vicious cycle of elevated ICP, impairment in cerebral blood flow, and ultimately to brain herniation. In the emergency department, we can use history and exam to rapidly identify patients at risk for TBI. And recall that patients with TBI need aggressive management of ABCs to mitigate secondary insult and to closely monitor their risk of elevated ICP and herniation. Recall that there are neuroprotective measures that can be employed during intubation for patients with TBI who have a GCS less than 8 or those in respiratory distress. And finally, recall ways to monitor and treat patients with signs of herniation. So thank you all for this opportunity to talk with you today. I am really looking forward to talking with you on this coming Tuesday and in Vietnam next month. These are just some references that I used for this presentation, and below you'll see my email. Please feel free to shoot me an email if you have any questions or any thoughts on any of this content. Again, really looking forward to working with you all and learning from you all coming up shortly. Thank you again for this opportunity.